Welcome to our video on recurrent pregnancy loss. Let's get started. Here's our overview slide. Let's begin with an introduction. Recurrent pregnancy loss is defined as 3 or more consecutive loss of pregnancies before 20 weeks of gestation. Here are the risk factors for recurrent pregnancy loss. A history of prior pregnancy loss significantly increases the risk of pregnancy loss in subsequent pregnancies. Uterine defects like a septate uterus, uterine fibroids, polyps, adhesions, and cervical insufficiency are also some of the risk factors. Maternal endocrine disorders like thyroid disorders, hyperprolactinemia, and luteal phase defects can also result in recurrent pregnancy loss. Thyroid disorders and hyperprolactinemia can suppress the hypothalamic pituitary gonadal axis by decreasing gonadotropin-releasing hormone secretion. This creates unfavorable conditions for the maintenance of pregnancy, as estrogen and progesterone synthesis will be decreased. A luteal phase defect is characterized by inadequate levels of progesterone to maintain the pregnancy, thus leading to pregnancy loss. Antiphospholipid syndrome is a highly testable risk factor for recurrent pregnancy loss, and it's an autoimmune disorder characterized by thrombotic events and recurrent pregnancy loss. A history of a loss of 3 or more pregnancies with a history of thrombotic events or endocrine disorders helps in the diagnosis of recurrent pregnancy loss. Paternal chromosome abnormalities can be detected by karyotyping. Hysterosalpingography is done to evaluate any anatomical uterine and tubal anomalies. Hysteroscopy is the standard test performed for direct visualization of the inner lining of the uterine cavity, cervix, vagina, and fallopian tube openings. Hysteroscopy, however, cannot detect the external abnormalities of the uterus, for which a laparoscopic evaluation is required. Here's an illustration that explains how the hysterosalpingogram works. A contrast dye is injected into the uterine cavity through a cannula. The dye fills up the uterine cavity and the fallopian tubes, after which a series of x-rays are taken. Any filling defect in the x-rays indicates abnormalities in the uterus and fallopian tubes, and spillage of contrast dye indicates that the tubes are open. Here is a hysterosalpingography image showing the cannula right here, which is injecting the dye in the uterine cavity, and we can see the fallopian tubes right here. Ultrasound can be used to differentiate between septate and bicornuate uterus. Laboratory tests for antiphospholipid syndrome include anticardiolipin antibody and lupus anticoagulant. Lastly, to rule out endocrine disorders, thyroid function tests and blood sugar levels are ordered. All right, now let's move on to management. Management of recurrent pregnancy loss depends on the underlying pathology. In vitro fertilization using a donor sperm or an egg can be done in cases of prenatal karyotype abnormalities. A luteal phase defect can be treated with progesterone, and antiphospholipid syndrome is treated with low molecular weight heparin and low-dose aspirin. Warfarin must be avoided during pregnancy due to its teratogenic effects. However, warfarin should be given to non-pregnant patients with a history of thrombosis. Surgical treatment is required for uterine anomalies, such as surgical repair of a bicornuate uterus and septate uterus. Cervical insufficiency is managed with cervical cerclage. Lastly, diabetes mellitus and thyroid disorders should be treated accordingly. All right, let's wrap up with a question. A 25-year-old female comes to the physician for a follow-up visit after having a spontaneous abortion 2 weeks ago. She has had 3 pregnancy losses all before 20 weeks of gestation. Abnormalities of her reproductive tract, thyroid disorders, and hyperprolactinemia are all excluded. She has a past medical history of 2 episodes of deep vein thrombosis. She has never taken oral contraceptive pills. Laboratory findings are significant for a partial thromboplastin time of 50 seconds, the presence of which antibody best explains this patient's recurrent pregnancy loss. All right, this patient has recurrent pregnancy loss and 2 occurrences of DVTs with no history of taking oral contraceptive pills. Additionally, her partial thromboplastin time is elevated at 50 seconds. All of these findings point towards the diagnosis of antiphospholipid syndrome. A falsely elevated partially thromboplastin time is explained by the presence of lupus anticoagulant in this patient. Lupus anticoagulant is an antibody to membrane phospholipids which impairs fixation of the clotting factors in the test tube, resulting in a high PTT. Since lupus anticoagulant binds to phospholipids on the cell membranes, it can damage the endothelium, predisposing the patients to thrombus formation. Hence, even though antiphospholipid syndrome is characterized by a prolonged PTT, it actually induces a hypercoagulable state, which can lead to recurrent pregnancy loss. So the answer to the question is lupus anticoagulant. And that concludes our section on recurrent pregnancy loss.